Hi, this is Neil Hansen, and I'm taking you through a CT urogram. So this is a study that's usually obtained with the indication of hematuria. It consists of a CT abdomen and pelvis both with and without contrast. Usually we're looking for something that caused hematuria, which is oftentimes a urothelial neoplasm, especially in older adults. The first thing that we get is a non-contrast scan, and the non-contrast scan is obtained for the main reason of looking for renal stones. So you can see here that this person had a tiny renal calculus, if I zoom in here, in the right kidney, which is a cause of hematuria. And I'd say just statistics-wise, if we find a cause for hematuria on these studies, it's oftentimes non-diagnosed nephrolithiasis. I always go down and look at the bladder too for two reasons on a CT urogram. One, you can have bladder stones, especially in like guys with BPH, they'll form stones, or people with neurogenic bladder, and those stones can cause irritation and hematuria. And then two, I find that actually looking for urothelial neoplasms in the bladder, if you aggressively window it, you can frequently see them to better advantage than you can on delayed post-contrast phase. And here, this person actually had a big bladder tumor. If I window it correctly, you can see here that there's a high attenuation mass partially calcified within the anterolateral left aspect of the bladder right here. It was actually kind of subtle to find. The person that found it, I think, did a good job. And it's also a teaching point. So transitional cell carcinoma in the bladder can calcify even before treatment. So if you see any bladder wall calcifications, that needs to have a cystoscopy and biopsy, because there's a high association with urothelial neoplasm. The bolus that we give for the post-contrast imaging, which is on the right hand of the screen, is unique in CT urography because it's a split bolus. We give the initial half of the bolus at time point 0, and then we wait about 7 to 10 minutes, and we give another bolus, and then we wait about 100 seconds, and then we scan. And that way we get what's called kind of a mixed phase of scanning for the CT urogram. So for the split bolus, the first part of the injected contrast ends up in the ureters, which, if I zoom in here, you can see the right renal pelvis here is opacified with contrast. You can see the little calyceal tips here within the kidney parenchyma, and you can follow the ureter all the way through its course down to the bladder. So that's where the first bolus ended up. The second bolus ends up in the renal parenchyma, because that's about 100 seconds after contrast administration, and we do that to evaluate for renal masses. Here you can see there's a tiny hypodense probable cyst in the kidney, but really this phase is best for seeing solid renal tumors like renal cell carcinoma, which can sometimes present as hematuria. Oftentimes I will look at this both in a soft tissue window to look at the urothelium, and then especially if the contrast is really dense, I'll put it on a bone window and I'll scroll through it also, all the way down into the bladder, looking for any urothelial filling defect, stricture, or mass. And then you can actually see here within the posterior lateral bladder on this post-contrast nephrographic phase, we found a second small mass. This actually turned out to be a blood clot at cystoscopy, but you can see it outlined by the contrast entering into the bladder. The mass was actually more superior, and it's actually kind of difficult to see with the contrast in unless you window it very aggressively. You can see here it was an anti-dependent tumor in the bladder dome.